Good evening and welcome to this evening's video seminar by Care. I'm Tony Rutherford. I'm one of the consultants at Care Fertility Leeds. I've been working at IVF for around 39 years now. Tonight we're supported by Lauren and Chloe. Chloe's here to write down your questions. Lauren's going to be helping to answer a few questions. Lauren's from the new patient team. Inquiries team here at Care. So I'm going to take you through a presentation, the beginner's guide to understanding fertility. So we can talk about the first part of your fertility journey and then the main treatments that we offer at Care Fertility. So to begin with, let's Care. Let's say a little bit about Care. Care is the largest provider of fertility services in the UK, and we've got clinics all over the country, and there are new clinics coming on stream in Plymouth and in Cardiff, so we're going into Wales, and we provide treatment too in the USA and in Spain. In Spain, they offer a very good egg donation program, and we can use that to bolster our own excellent program too. The first part of your journey is to meet up with one of our patient inquiry team, and they will help you book an appointment with one of our fertility specialists. Prior to the making that appointment, obviously you want to try and get the diagnosis right. Make sure that your consultation with your consultant actually works and they've got the right information to help reach the right diagnosis. So there are three basic tests that we usually do, pre-treatment tests. If you are in a heterosexual relationship, we would want to do a sperm test for your male partner, and then for the female partner, we would want to do two things: to look at your ovarian reserve, how active your ovaries are. To do that, we look at a hormone known as AMH, which is made by the hormone-producing cells that surround the eggs as they grow. AMH is only made by the hormone-producing cells as the egg grows. So it's a really good guide as to how many active eggs you have growing at any one time. A pelvic ultrasound scan not only looks at the anatomy of the uterus, the womb, where the embryos are going to grow, but also it looks at the ovaries and it looks at the antral follicle count, how many little eggs we can actually see on the ovaries at any one time. It tends to be fairly constant, and the antral follicle count and AMH will change with age. Once you've had your basic investigations, you then see your consultant, and we have a wide range of consultants in the clinics at Care. Each consultation will take around 45 minutes. In that time, we'll take a very detailed history from both you and your partner. We will look at the test results, the ones you've had performed prior to your consultation, talk you through the results, and then point you in the right direction of what treatment we think is going to be most appropriate for you. There may be a range of treatments, but we'll always give you an opinion based on our experience, what is going to be right for you, and taking into account your history, the test results, and perhaps the length of time that you've been trying. You may need some extra tests, and the consultant will discuss that with you at that initial consultation. If you've got all the tests available and you can proceed on to treatment, we can proceed on to treatment straight away. It could be that you just need to have a couple of basic extra additional tests performed, which we could then review, and if they're normal, we could then proceed on to treatment. We use a patient portal to help support and provide information to you, and that can work either across your desktop, on laptop, on mobiles, and on tablet devices. And very soon we'll also have an app which should be available to all our care patients too. So you keep an eye on your portal for very important messages. So let's talk about the IVF process. We're going to talk briefly about ovarian stimulation. Naturally, you just produce one egg a month, but what we're interested in is maybe getting 10 to 15 eggs so that we can maximize your chance of success. The reason why IVF works in infertility practice is that, let's say in an average year, you ovulate 12 to 13 times. There are only 12 to 13 times, 12 to 13 eggs exposed to sperm in that time period. If we go through an IVF cycle, we may get 10 to 15 eggs. Well, if you add, say, 15 to 11, you can see automatically that we've got 26 eggs exposed to sperm in a given time period. So it increases the likelihood of finding that one egg which will form a healthy embryo and help you produce a baby. We're then going to look at the monitoring, what we do, how we gauge which is the right time to do your egg collection, and talk to you briefly about the egg and sperm collection prior to mixing them and fertilizing the eggs. So what do we do with ovarian stimulation? The natural hormone that makes you produce your egg is called FSH, follicle stimulating hormone. And it does what it says on the tin. It stimulates the follicles to grow. Naturally, in your own normal cycle, you may have 10 to 15 small follicles present at the beginning of your cycle. The body releases just a small amount of FSH. If you can imagine, you've got 15 little glasses of water, all at varying levels of fullness, sat in front of you, and you've got 2 gallons of FSH in a jug. You share it out evenly between each of those glasses. The one that's closest to being full overflows first. That's going to be the follicle in your natural cycle that is going to grow and from which the egg will be released. In IVF, what we want to do is not just get one glass to overflow, we want to get maybe 10 to 15 to overflow. So instead of just giving you a jug with 2 gallons of FSH, we give you 10 gallons of FSH so we can fill more of the glasses. That's the basic principle of the ovarian stimulation process. We're not using up your egg supply. The eggs that we're going to stimulate have already taken 9 months to get to this point. If they're not chosen, they simply go down the conveyor belt into the dusty bin and they're not going to be used. Their time has gone. So what we're doing with the IVF process is rescuing eggs that were otherwise destined to die. So what do we use? We use this FSH. It is a natural hormone. It is a protein. And so if you took it by mouth, you would simply digest it like a piece of meat. And therefore, we give it by injection. But don't worry, it's a really small diabetic type needle. We mix the fluid and then you pinch an inch and just put it into the front of your tummy or the top of your thigh. and we'll teach you what to do. It's a very straightforward process. Most women are going to need around about 10 to 12 days of injections. We're going to give you a second injection from about day 6 of your cycle to block you ovulating. If we didn't do that, about a third of women would release the eggs too early. So the blocking drug, again an injection because it's a protein, is given usually in the morning. And it usually takes that for about 5 to 6 days. And you'll be advised when to take them, these injections, and when to stop them. We monitor the process using ultrasound. Many of you may well have already had an ultrasound scan. It's an internal ultrasound scan using a transvaginal probe. Why do we use that rather than a tummy probe? Because we get really close to the ovaries and we can see the ovaries very clearly. We can measure the size of the follicles in which the eggs are growing very precisely. And we then work out when's going to be the best time to give you a trigger, ovulation trigger injection. Normally we'd want to see at least 3 follicles above 70 millimeters when we actually give the trigger injection. And the trigger injection is normally given at a very precise time at night. What we do then is perform the egg collection 36 hours after this trigger injection. The egg collection process is called a transvaginal egg collection. Occasionally, we might need to collect the eggs through your tummy using a needle through the tummy wall, but over 98% of egg collections are performed transvaginally. It's done under sedation anesthetic. What do I mean by that? This is not a full general anesthetic. It's sedation. So you will be awake, but you will not remember anything about the egg collection. You're given a drug known as Hypnoval. It's midazolam, which is helps to, as it says on the tin, hypnotize you. And then you're given a very powerful painkiller, fentanyl, which takes away pain. We also put some local anesthetic into the top of the vagina to try and make it also less uncomfortable when the needle is put in. We use a suction pump to drain the fluid containing the eggs. When you have the trigger injection, it initiates 2 processes. One is to mature the egg to get it ready for fertilization with the sperm. But the second is to free the egg from the wall of the follicle so it's floating in the fluid. So when we stick the needle in, we'll get the egg out in the liquid. Normally, we would expect to get eggs, say, out of 8 eggs out of 10 follicles. So we get an egg in about 80% of cases. Once we've got the egg, we have to get some sperm. And the husband goes and provides a sample. And Chloe's going to show us a little video of the sperm. If we can get it started, Chloe. Here we go. And so we get a sperm sample. If you've got a really good sperm sample, then we can simply mix the eggs and the sperm together around about 40 hours in a Petri dish. It used to be a test tube, hence the name test tube babies, but now it's done in a Petri dish. Next slide, please. Thank you. Oh. So now we're going to talk about the rest of the fertilization. If, however, you have a low sperm count, we can inject a single sperm into the egg cell, and Chloe's going to show us the second video now, and this is about the ICSI process. ICSI was developed in Belgium in 1992. That was the 1991. Sorry, that's the name. It's 92. So that was the date of the first baby born following ICSI. And you can see here that this glass pipette it sucks up the skin of the egg, and then there it is. The sperm is injected into the egg. ICSI was developed by accident. They were trying to get the sperm inside the egg cell that you can see just on the outside here, eggshell, but outside the egg itself. But they slipped and it went in and it worked. The egg fertilized. So they then repeated it and it worked again. So ICSI has revolutionized the treatment of male factor fertility problems. And from going from only being able to treat 13% of male factor, even with IVF, we can now treat 87% of male factor problems using the ICSI treatment. ICSI is used in about 44% of all our fertility treatments. We then leave once the sperm's been injected or the egg is placed with sperm, we leave them overnight to see what proportion of them will fertilize. Around 60 to 70% of eggs will normally fertilize. They're then grown in an incubator in undisturbed culture for a total of 5 days. We used to do embryo transfer on day 3, but we now know that 40% of embryos we chose to put back on day 3, we wouldn't put back on day 5. So by moving to day 5, we're able to select the best single embryo to go back, which means that we reduce multiple pregnancy rate, which makes it much safer for both the baby and the woman that's carrying the baby. So single embryo transfer is the best way forward. Now we've got some pictures. We also, in Care, have this very clever incubator, which takes a picture of the embryos every 10 minutes. And you can watch the embryo grow. And we look at 7 different time points in the embryo development, which tells us which is going to be the right embryo to go back. And we use an artificial intelligence program which calculates which is going to be the best embryo to go back, with a score of up to 10, 10 being the highest score. Here you can see an embryo that's forming, it's multiplying, the cells are dividing all the time. And by the time it reaches a blastocyst embryo, it's got between 120 to 160 cells. You can see it's just beginning to poke out or hatch from the side there. It's hatching out of the zona pellucida, or the eggshell. And we watch that using the incubator. And if you use the time-lapse imaging that Care maps, you can actually get a video of your embryo. So that's one method of trying to work out which is going to be the best embryo to put back. The second way we can look at it is that we know that as you get older, one of the reasons why IVF doesn't work is because an increasing proportion of even your good quality embryos may be chromosomally abnormal. They may have the wrong carrier type. And this is an impact of age and on the egg cell itself. So from 37 years onwards, or earlier if you have a history of miscarriage, we will offer you to do pre-implantation genetic testing for aneuploidy, PGTA. This involves taking a small biopsy of the cells that are going to form the afterbirth, the trophoblast. It doesn't touch the embryo, the cells, the inner cell mass that are going to form the baby itself. Those cells are taken off after a little hole has been drilled through the zona pellucida, and those cells are separated off, and then they're analyzed to look to see whether they're chromosomally normal or not. At the age of 38, for example, we know that 50% of embryos, even your best embryos, would be abnormal. As you get up to 40, 66% of embryos are abnormal. So PGTA is very useful if you are getting older in trying to select the right embryo to go back. If we put a normal embryo back, it increases the chances of that embryo implanting and forming a baby. It reduces your risk of miscarriage. And furthermore, it reduces the time to pregnancy. Now, we do hope that you will have embryos spare. If we're putting one embryo back, we hope there'll be embryos spare, so they're cryopreserved for your future use. In our clinic in Leeds, between 50 to 60% of patients have embryos frozen. There may be an occasion where we suggest that you have embryos frozen. For example, if you produce more than 20 eggs, or you've got polycystic ovaries where there's a likelihood you're going to produce lots of eggs, we may recommend that you electively freeze the embryos. Why? Because research shows that by freezing the embryos and then putting them back in a hormone replacement cycle gives you a better chance of a successful pregnancy. Why, you might ask? Well, it's likely to be related to the endometrium, the lining of the womb. If you produce lots of follicles, you're going to produce lots of estrogen, and that may make the endometrium develop too quickly, such that when the embryo is ready to go back, the endometrium is past its best. So we only freeze if we think it's necessary, or recommend freezing if we think it's necessary under these circumstances. But we do hope that a significant proportion of people will have embryos frozen. We also, if you're going to go through the PGTA process, have to freeze the embryos, because once the biopsy's been taken, we need to analyze the results, and it takes 2 weeks to get the results of the tests. And then we keep the normal embryos in the freezer and dispose humanely of the embryos that are not going to form a baby. So what about the embryo transfer? It all comes down to this last little bit, the embryo transfer. The embryo transfer is really straightforward. It is a bit like having a smear taken. The embryo is left in the incubator till the last minute, and then we perform the embryo transfer with you having a full bladder, so we can actually have a look at the womb to find out where the embryo transfer catheter is going. The catheter is really fine, so you will have a speculum in, like the smear test, with a full bladder, so it can be a little bit uncomfortable, but the transfer itself is a relatively painless procedure. And again, we'll put one embryo back at a time. If we had elected to put 2 embryos back, say for example, in somebody who's not had PGTA testing and was over the age of 40, or the embryo quality was not as good, and therefore we couldn't pick out which was the best embryo, you may have 2 embryos put back, but they would all go back, they'll both go back at the same time using this technique. The embryo transfer process takes about, in total, about 10 to 15 minutes. Now, not everybody has IVF. For some people, IUI is the right treatment. IUI stands for intrauterine insemination. This is IUI is normally done in your natural ovulation cycle, although we can occasionally give you medication if the first 3 cycles are unsuccessful. IUI is generally reserved for couples that are unable to have sex naturally. For example, if there are difficulties with a male with erectile dysfunction, or in a woman if she has acute vaginismus and is unable to have penetrative intercourse. We can perform the IUI procedure under sedation to help under these circumstances. If you're a same-sex couple and you're having donor sperm, then we would prepare it using IUI. It's a really simple technique. The first cycle of treatment, we will normally monitor with ultrasound to make sure we know when the follicle is developed to the right time, what's going to be the right time to put the sperm back. And we ask you to do urine prediction kits to detect when you're ovulating and make sure that that coincides with your scan picture. The IUI is a bit like the embryo transfer, uses a very similar catheter, and the prepared sperm is put back through the cervix into the womb cavity. Now, in many women, we may decide to do an IUI treatment at least 3 cycles without checking your fallopian tubes. But if your history suggests that there may be tubal damage, then we may check your fallopian tubes with a simple test called a high COSY prior to doing the IUI treatment. What about donation with care? We have sperm and egg banks at Care Fertility, and we also work with sperm banks overseas, Cryos International European Sperm Bank, and the California Cryo Bank too. And there are other London sperm banks that we work with too. We have really good industry-leading success rates with our egg donation program. We tend to use frozen eggs, although you can have a fresh cycle if you wish. The advantage of the frozen egg bank means that you've got greater choice of donors at any particular time. So you can quickly access and choose the egg donor of your choice. The treatment cycle itself is relatively straightforward in that it's like having a frozen embryo transfer. We prepare the lining of womb using hormone replacement therapy to get the endometrium ready for the embryo transfer. Another advantage of the egg donation treatment care is that it can take place in the UK, removing any uncertainty about moving abroad for treatment. We can also offer surrogacy. In some circumstances, a woman may be born without a uterus, or it may be that she's had to have a hysterectomy, for example, with cervical cancer, but has retained ovaries. So we can collect the eggs, mix them with the partner's sperm, and use a surrogate to carry that pregnancy. A male same-sex couple would need a surrogate to carry a pregnancy. We believe that family is for everybody, and in today's society, we can help all families, everyone have a family. The surrogacy we're going to talk about a little more in one of our later presentations. We've got lots of support at Care Fertility for your fertility journey. Everybody is unique, and you are treated as an individual along your journey. So we can help you have a family. There's lots of support. There's our new patient inquiry team, like Lauren, who is going to be on this call later, who's really they're really clued up on our fertility treatment and the treatment options available to you. We have a care forum which you can resource. We've got lots and lots of patient information. We've got our Care Pals team, who again, friendly advice. We've got social media platforms, and at times where perhaps everything gets a little on top of you, we have a counselling support system too available, and that's just a phone call away. We have various funding programs. We've got an IVF multi-cycle program. We've got an IVF refund program too for those that qualify. And then we've got various donor egg IVF refund programs too. So you can speak to one of the Care Pay advisors and see whether any of these programs would be suitable for you. Now we do have some more virtual information events this January. You've got one with Tom Bamford that's going to look in a little more depth at surrogacy, and Professor Charles Kingsland, who is a very humorous, very knowledgeable professor, a very close friend who I've worked with for many years. And they're coming up later on this month. So now we're going to go, and hopefully we're going to try and answer a few questions. So I've got, I'm just going to close that down, and so we can see each other a little bit more clearly. So there's a couple of questions on the board. I'll read them out to you, and we can, if any of you have got questions, please don't hesitate to put them on the board, and so Chloe can let me see. So first of all, does AMH correlate with egg count, or can they show two different results? On the whole, you'll generally find that AMH and antral follicle count should be similar. But occasionally, you might find situations where the antral follicle count is a bit higher than the AMH. And we as doctors know that when you're looking at a scenario like that, it's likely that someone will respond more closely to the AMH than the antral follicle count. And that's why we don't just want to rely on one simple test. We want to have both those tests, and we use them to help choose the right dose of medication for your stimulation. It's appropriate to try and, personalize your treatment each time. So what is a side effect of follicle stimulation? So once you've had your egg collection, do your ovaries go back to a normal size quite quickly? The answer to that question is they do. It's amazing. When you ovulate naturally, the space that's left behind the follicle turns into a gland called the corpus luteum. That produces the hormone progesterone. And that corpus luteum has a finite lifespan of 12 to 14 days. If you don't conceive, and there isn't any fetal HCG, the pregnancy hormone HCG in your system, then that gland will go into self-destruct mode after 12 to 14 days, and then you'll have a period. With IVF, those glands last the same time course, and they quickly go back to normal, and the ovary shrinks back down to a normal size quite quickly afterwards. Is there a difference between day 3 and day 5 embryos? The reason why we tend now to do day 5 embryos, research has shown that if you choose your embryos for transfer on day 3, 40% of those embryos wouldn't be the embryo we would naturally select on day 5. Why are we selecting them, leaving them in the culture dish longer? Well, we now know, and we've known for around about 20 years now, that embryos don't like the same concentration as oxygen to us. Why should they? They actually live in the fallopian tube, and they have to get oxygen, which is dissolved in the bloodstream and comes out. So it's a much lower oxygen tension. It's about 4%. So now, once we learned that, we learned that we could keep the embryos in culture for a lot longer, to day 5. And then we know that some embryos, if you had 10 fertilized eggs, only 5 would reach the blastocyst stage of development. So there's quite a high attrition rate. So it's best to get a blastocyst embryo to go back, because that gives you a higher chance of a pregnancy per embryo. Is everybody on the same dose of stimulation? And the answer to that question is no. We individualize it, because some people don't need very much. For example, if you've got polycystic ovaries, you might need a very low dose of stimulation to get the eggs and the follicles to grow. If you've got a low AMH and a low antral follicle count, you might need a higher dose of stimulation. In general, you need more stimulation as you get older. So we do vary it dependent on your circumstances. Is there anything to improve my fertility before your treatment? I think there are loads of things that you can do to make your chance of success better. First of all, diet's important. If you, the research would suggest that a Mediterranean style diet, high in protein, low in carbohydrate, with lots of antioxidants, is best for fertility. There's actually a book, the Mediterranean Diet Cookbook, which has lots of really tasty food in. It's important that you try and get your weight. If you are a little bit overweight, try and get the weight normalized to being 20 and 25. If you are of normal weight and you enjoy your exercise, don't do too much high intensity training, because we know that if you go high intensity training and you've got a normal BMI, if you train more than 3 times a week, it will reduce your chances of success by up to 40%. You don't smoke, and you drink no more than 5 units of alcohol per day. So there's lots of things that you can do. It's important you take vitamin D. 84% of our population, particularly at this time of year, are vitamin D deficient. And just taking a simple vitamin can markedly increase your chances of success. So those are just a few things you can do. How can we improve your sperm result? Again, it's quite difficult to improve sperm, but again, if you're overweight, lose weight. Testicles are outside your body for a particular reason. They need to be cold. Don't go and sit them in a hot bath for half an hour at a time. Don't go into the sauna. Keep your testicles cool. Don't wear tight lycra all the time. Wear some baggy underpants. Try and keep the testicles cool. There are foods which, again, would help. Mediterranean diet is one, but foods rich in vitamin C, vitamin E, selenium, which you might find in Brazil nuts, and zinc that you find in fresh meat. Those are all things which will help improve the sperm. Can you have a double embryo transfer? As I said, that we try to put one back at a time, so you can have one baby at a time. There was a directive that came out of our regulatory body, the HFEA, back in 2007. At that point, up to 25% of all IVFs were multiple pregnancies, either twins or even higher than twins, and that we were occupying many special care baby unit cots with IVF babies. We know that with a twin pregnancy, 1 in 12 women that have a twin pregnancy would have a dead or handicapped baby. So by putting 2 embryos back, particularly at the blastocyst stage where there's a higher chance of implantation, We weren't improving the pregnancy rates that much, but we certainly were increasing the risk of having twins, and therefore potentially having an adverse outcome. So we try to make it one baby at a time and put the other embryo in the freezer. If it's good enough to form a baby, it'll be good enough to survive in the freezer and go back at a later time once you've had one baby at a time. What's the best fertility option for a man who's abnormal defects in sperm shape and low motility and morphology? So if you've got a high level of abnormal sperm, and in particular you've got low sperm motility, then ICSI is likely to be the best mode of fertilization. Sometimes it's difficult to gauge whether you could fertilize normally or not, but taking into account the length of infertility and the complexity of fertility treatment, ICSI is probably the safest and best option in a lot of these cases. Are all the hormones a woman has to inject into herself any risk to the baby in the way the baby developed? It's a very good question. And IVF has been around now for many years. The hormones we give you in the IVF process are either the natural hormone itself or a modification of a natural hormone. And these do not harm the baby. The pregnancy, the incidence of abnormalities following IVF are very similar to those you'd expect in a normal population. Next one, how progesterone level affects successful transfer. Mine's usually very low and hard to lift with injections or tablets. Progesterone is important to success rates. We know from research done early in, well, it was early 80s, I think, by a chap called Michael in Bristol, that the progesterone level in conception cycles needed to be around about 28.6 nanomoles per liter. That's the value that you need to have. In an IVF cycle, in general, certainly to begin with, you're going to have lots and lots of progesterone, but we still give you some support, because after about 7 days your progesterone might fall a bit, so we give you that extra support. The time where you might need some additional support is in a frozen embryo transfer, and recently in Care, we've, based on some research from the Care unit in Birmingham, we've increased the regular use of pessaries to 3 a day, and we check the progesterone after 3 days, and if necessary, add in a either subcutaneous or intramuscular progesterone injection. And that seems to do the trick to get the progesterone levels high and increase the pregnancy rate and lower miscarriage rates. Okay, so I think those are all the questions now. I'm sure that there are going to be facilitators around the GEM team are going to be around to 8 if you want some help with booking appointments. But I hope you found that useful, and I hope you will think about attending perhaps one of our future sessions coming up in January and then throughout the year. So good evening. Bye-bye.
I'm Shah, and I manage Care's new patient inquiry team. We're here to make it easy for you to take your very first step in your fertility journey. We completely understand how nervous and excited you might be when you contact us. This is the start of a life-changing process and hopefully the beginning of an amazing future as a family. So it's really important that we give you all the information you need. That way, we can help you to feel much more comfortable and confident with your treatment. Whatever you need to talk about, I want to reassure you that no question is silly or trivial. We appreciate that there might be a lot to take in at first, but don't worry, we'll send you a clear information pack about the treatments you're interested in, and we're always here for any follow-up queries. My team also manage inquiries about Care Pay, our range of funding packages which are exclusive to Care Fertility patients. When you're ready, we can book you a virtual consultation with a specialist fertility doctor from your local care clinic. So, if you want more information, have a question, or wish to book an appointment, call my team. We want you to know that we are here for you at every stage of your fertility journey. We say that our patients become part of our care family, and it's true. We care deeply about you and your future, and our teams are here to make sure you have all the support you need.
The reason why we chose Care was just, one, the care that they give you, the aftercare that they have available to you, and the fact that they offer different forms of treatment, and they listen to you. One thing that I've identified and what I've noticed when speaking to other people that I've met within the infertility community is there's a lot of clinics out there that don't necessarily listen to you as the patient. It was kind of a one size fits all, but with Care that didn't seem to be the case at all. They took everything into consideration, and they listened to your concerns, they listened to you as a person, and they put a package and a process in place that will help you, and fingers crossed, will give you that positive result at the end of it. So without a shadow of a doubt, if I had to go through it again, I would definitely go back to Care.
Oh, the support at Care was brilliant, yeah. I mean, the nurses were brilliant for us. You feel so
looked after,
cared for by the whole team. We felt that they did care, and it wasn't just for them getting something out of it. It was actually that
ongoing support.
Yeah, and they wanted it to work for us.
Care Fertility started over 20 years ago with one clinic and the goal of helping patients achieve their dream of family through truly personal care and the most scientifically advanced fertility treatments. We've grown from that one clinic. We now have clinics across the UK, and many people have become part of our care family with over 50,000 care babies in the world. But one thing has and always will remain the same. We care for each and every patient. We care about your dreams of having a baby, and we put our heart and soul into every aspect of what Care can offer you. To provide you with the best care possible and to give you your best chance of success in treatment, we look to our own care family. From our consultants, embryologists and nurses to our admin teams and specialist fertility counsellors, we've also put a lot of thought into how we improve each and every step of your journey, which will no doubt begin with lots of questions. We know that thinking about starting IVF can be daunting for some, and that's why our care, patient services and support teams will always be there for you whenever you have a question, need advice, or simply want someone to talk to, so that you feel completely confident and in control of your fertility options. So yes, we have grown and developed over the years, but care and empathy are always at the heart of who we are. We are passionate about changing lives and creating futures, and I hope that this shines through in everything we do and everyone you meet at all of our clinics. We don't just care, we are Care.